insulin. Also, the other side effects will be discussed. So starting off with the adverse effects of insulin, hypoglycemia is a common side effect of insulin, particularly in type 1 diabetes patients on insulin therapy. It is defined as blood glucose levels less than 70 milligram per deciliter, and it may present with signs and symptoms that can be classified as autonomic symptoms or neurogenic symptoms and neuroglycopenic symptoms. So autonomic symptoms are thought to be mediated by adrenaline or epinephrine, and therefore these are also known as adrenergic symptoms, and the symptoms includes palpitation, tremor, weakness, intense hunger, excessive sweating, and these are thought to be mediated by epinephrine. The other type of symptoms is also known as neuroglycopenic symptoms because the brain and the neurons are starved because of less glucose, and therefore these symptoms are known as neuroglycopenic symptoms, and the patient presents with difficulty in concentration, impaired judgment, lethargy, irritability, weakness, agitation, and when the symptoms become more severe and because of prolonged hypoglycemia, there can be behavioral disturbances and the patient can present with seizures and coma. So now let us see why is glucose important for the brain, what are the physiological responses to low blood glucose level, why clinically significant hypoglycemia rarely occurs in a non-diabetic individual, and what are the circumstances that predispose a diabetic patient to severe hypoglycemic reactions. As we know that the brain's function depends on glucose, and because the brain cannot synthesize and store glucose, it is dependent on constant exogenous quantity via brain's blood supply. So, there are various feedback mechanisms that restore the plasma glucose concentration to normal and serve as protective mechanisms against hypoglycemia. So, what are the physiological responses to low blood glucose level? When the blood glucose concentration falls between 50 to 60 milligram per deciliter, glucagon is the main hormone that is responsible for acute recovery from insulin-induced hypoglycemia. Epinephrine levels also rise, and these also help in acute recovery from hypoglycemia. As the hypoglycemia becomes prolonged, cortisol and growth hormone are released into the circulation, and all of these hormones tend to restore the blood glucose to normal. So in a healthy non-diabetic individual, clinically significant hypoglycemia is rare. This is because of the counter-regulatory hormonal responses raising the plasma glucose concentration to normal, and therefore hypoglycemia rarely occurs. But in a diabetic individual, there is defective counter-regulatory hormonal response, and this predisposes to severe hypoglycemic reactions. Also, certain medications such as non-selective beta blockers diminish the adrenergic signs and symptoms, so the patient does not experience the symptoms of hypoglycemia, and this can lead to hypoglycemic unresponsiveness or hypoglycemic unawareness. So the patient does not feel the symptoms of hypoglycemia, and this can further lead to hypoglycemic reactions. Thirdly, there is a phenomenon known as Somo-Guy effect, which I have discussed in my previous video. And in this phenomenon, there is nocturnal hypoglycemia, hypoglycemic stress during the night time, and this is due to intense insulin therapy during the bedtime or skipping meals during the bedtime, which can cause nocturnal hypoglycemia or hypoglycemia during the night time. And this can lead to defective counter-regulatory hormonal response and lead to morning hyperglycemia. And to control morning hyperglycemia, the physician might increase the dose of insulin. So by increasing the dose of insulin, this can lead to repetitive hypoglycemia during the night, exacerbate the condition. Therefore, hypoglycemic attack needs to be recognized, promptly treated. Also, physical activity and exercise increases the risk of hypoglycemic attack. So, repetitive severe hypoglycemic reactions can cause permanent neurological damage and can cause worsening of retinopathy. There is a syndrome known as dead in bed syndrome, which is described in diabetic patients on insulin therapy, and these patients suffer from repetitive hypoglycemia and also have an underlying cardiovascular abnormality, and this predisposes these patients to hypoglycemic attacks, and therefore these patients die in their sleep, and therefore this is known as dead in bed syndrome. So hypoglycemic attacks can be very fatal, and therefore it needs to be prevented and promptly recognized and treated. The patient should be explained about the symptoms of hypoglycemia and warned about the dangers of missing meals or excessive exercise and alcohol, and the patient should be advised to take sugar with the first onset of symptoms so that hypoglycemic attacks can be prevented. So coming to the treatment of hypoglycemia. So how to treat hypoglycemia? Hypoglycemia can be classified as mild, moderate and severe hypoglycemia. In mild hypoglycemia, the cerebral function is not diminished. So the patient experiences symptoms such as headache, intense hunger, palpitation, tremor, weakness, and the patient is advised to take 15 grams of glucose followed by 15 grams of second dose of glucose in 15 minutes if the patient is symptomatic. While in moderate hypoglycemia, the brain function is diminished, so there is difficulty in concentration, dizziness, lethargy, weakness, impaired judgment. So the patient requires assistance for treating. And in severe hypoglycemia, the patient becomes unresponsive, unconscious, there can be convulsions and coma. So this is an emergency condition. For the treatment of moderate to severe hypoglycemia, glucagon can be administered subcutaneously or intramuscularly. Intramuscular route is preferred, but the glucagon can be injected into the deltoid region or anterior region of the thigh. In an emergency situation, if the patient becomes unconscious, a bolus dose of IV glucose is administered and the glucose is continued till the patient regains consciousness and eats normally. So now let's move on to the other side effects of insulin. Insulin is known to cause lipodystrophy at the injection site, and this is of two types, that is lipohypertrophy and lipoatrophy. Lipohypertrophy presents as a spongy lump at the injection site. It is due to the lipogenic property of the insulin, the property of the insulin to synthesize fat, to synthesize triglyceride, and therefore it presents as a spongy lump. This is due to repeated injection over a long term for prolonged period, and because of the lipogenic property, there is the synthesis or there is deposition of fat in that particular injection site. So here the treatment would be to rotate the injection site to avoid the same site again and again and change the injection site. On the other hand, lipoatrophy means loss of fat tissue at the injection site, and here the treatment consists of injecting insulin at the borders of the lipotrophic areas. So the next side effect of insulin therapy is obesity. So insulin therapy without dietary restrictions can lead to body weight gain. Insulin can also cause presbyopia, which is a condition of the eye, and this occurs because rapid control of hyperglycemia with insulin, and this can cause alteration in the physical properties of the lens. So because of the alterations in the physical properties of the lens, there is loss or diminished visual accommodation. Lastly, insulin allergies can occur with various types of insulin preparations such as insulin detamers, glargine, protamine and so on. However, true insulin allergies are rare. These reactions can occur because of additives to the insulin preparation such as zinc, protamine and other substances.